Good evening. I always say poor electrophysiologists. They get one lecture in the whole conference, and it's always the last one. Always. Anyway, I hope next conferences will have a session at least, and not the last session. Anyway, we'll start with a very interesting topic, sudden cardiac death, presented by my friend, Mohammad Hajjiri. He's a consultant electrophysiologist, well-known and a great guy. Please, Mohammad.
Thank you very much. Thank you for the invitation. So I'm going to be talking about sudden cardiac death. Every year, we lose someone for sudden cardiac death. And the diagnosis is always al-marid injalat. The patient had a heart attack. And most of the time, it's really not. There's a lot of other reasons for sudden cardiac death than just an acute MI. And as we do recognize that acute MIs do happen in younger patients, but we should never ignore the other preventable diseases that if diagnosed early, we're able to prevent sudden cardiac death in younger patients. So these are all just a few titles of, we always hear, somebody died, لحظة وفاة شاب بنوبة قلبية أثناء ممارسة الرياضة. This is another physician who died. Before that was another physician. And we hear that all the time. So sudden cardiac death, the center in sudden cardiac death really is ventricular tachycardia. And just a quick refresher of what VT is. It's 3 consecutive beats, more than 100 beats per minute. Non-sustained VTs is anything less than 30 seconds, and sustained VTs are anything that more than 30 seconds, or if they cause hemodynamic instability. So, and it's a wide spectrum of symptoms, right? We're all cardiologists, and we all have patients either come with palpitations or shortness of breath or some chest pain, and this is what they come from. So, sudden cardiac death. We have to think about structural heart disease and no significant structural heart disease. And due to the interest in time, I'm just going to go through some of the very important things that sometimes get missed when tackling with these symptoms. Secondary and primary prevention, just a view refresher of when secondary prevention is when somebody has already had a sustained VT, and primary prevention is when we're trying to prevent sustained VT. Okay, so let's talk about channelopathies. Channelopathies are an important part of sudden cardiac death. Let's talk about ARVC, arrhythmogenic right ventricular myopathy. So this is something that where it happens, it gets diagnosed in younger patients. Patients can come with syncope. Syncope, please do not ignore younger patients with syncope or exercise causing syncope. Yes, most commonly it could be something simple, it could be something like vasovagal, but we don't want our young people to be a title in a newspaper, Wafat Shab Ishrini. We don't want that. So one of the things are ARVC. Sometimes anterior precordial T-wave abnormalities, something we see here. Sometimes we see epsilon waves, but it's important to say that we do not see always epsilon waves. In fact, we rarely see that. We only see it in 20% of cases. We can do, if we suspect ARVC based on the clinical picture, cardiac MRI is very, very important. And unfortunately, it is not something that is widespread. It's not always available and everywhere. But cardiac MRI is something that we always we should try to use more cardiac MRIs to look for fibrofatty infiltration in the right ventricle, and sometimes the only thing we see is an abnormal right ventricle. So always suspect it. Suspect ARVC if you have an abnormal right ventricle on your echo, and then you can do a cardiac MRI afterwards. Typically, this is how the VT looks like. Okay, so these are different. We're EP, we like convoluted things, and we like to complicate everything. So we have to do a criteria for ARVC and D. These are different ways to diagnose, and these are the different criteria. We can go over them very quickly. We always have to do an echo. Sometimes an MRI, as I said, is very important. A biopsy can be helpful, and the single averaging ECG can also be helpful. Okay, so now we get the ARVC, we get an abnormal right ventricle, we do an MRI, we see a fibrofatty infiltration. fibrofatty infiltration is not, if you don't find it, but you find a low ejection fraction in the right ventricle and another low, then it can also cause low ejection fraction in the left ventricle. So let's not forget that. ICD, it's important. ICD saves lives. It's very important to get the diagnosis. Drug therapy and catheter ablation. Catheter ablation for VTs in ARVC can be helpful, but there's a very important medication called sotalol, which unfortunately it's not very available in Jordan, but it's an older medication. It's a class 3 antiarrhythmic. Sotalol is very helpful in patients with ARVC. So if we start someone on sotalol, is that enough without an ICD? No, it's not. But what you don't want is an 18-year-old who has an ICD, and this ICD keeps shocking him over and over. So sotalol actually reduces your shock, your ICD shock potential if you are diagnosed with ARVC. Beta blockers. Anybody who knows me knows I hate amiodarone. I think it's a nasty medication. We should absolutely try to avoid amiodarone as much as possible. I know that as cardiologists in Jordan, it's difficult to do that because that's the only medication that's available, but we have to try and do better with other antiarrhythmics. Catheter ablations, these can be actually very helpful, but then VT ablation in ARVC can vary in success rate from 60 to 90%, but it also has a recurrence rate, a higher recurrence rate. These patients, we have to tell them, you cannot do competitive athletics. And this is something, sometimes this is a very difficult decision that you tell to somebody who's an 18-year-old who wants to be a professional basketball player or professional whatever. So something that's very difficult. Screen all first-degree family members. HOCM is the most common of all these diseases. Autosomal dominant. But we have been seeing more HOCM patients that are isolated incidents, and they haven't really run in families, that the father does not have HOCM or the parents don't, and you just see isolated incidents of HOCM. You do an echo and you find this huge, massive asymmetric IVS that's more than 30 milliseconds, and we see that. Sudden cardiac risk is high in patients with HOCM, and we'll go over this. This is very important. I am sure that everybody in this room has diagnosed HOCM and has seen HOCM, especially in younger patients. Prior cardiac arrest, absolutely ICD. But as EP, you really don't want to run the risk. You don't want to risk death, right? Because death is irreversible. Once we're dead, we can't come back. So if we have HOCM, one of the things you really have to stratify. The easy part is that if you find more than 30 millimeters of IVS, of interventricular septum, obviously that's an easy one. Yes, we do put in an ICD, although it is in yellow, but we should put in ICD. But we also need to risk stratify patients whose IVS is less than 30 milliseconds. If it's 20 milliseconds, again going on with cardiac MRI. MRI is extremely helpful because it shows us the late gadolinium enhancements in patients with HOCM, and it's actually, if you find high LGE, if you find significant stratifiers, then an ICD, you do want to put an ICD. One of the other things is that you put them on a stress test and their blood pressure drops. There are other things that, if they have family history. HOCM, we don't want to miss HOCM. Patients do die, and Mahmoud, if you remember, once you consulted me on that patient, in the ER, unfortunately, these things do happen. Okay, so let's talk about idiopathic VTs and outflow tract. One other thing, actually, I want to say in HOCM is that if we do a septal myectomy, we really have to make the difference between symptoms from HOCM, where it's usually caused by SAM and systolic anterior motion, and sudden cardiac death. Septal myectomy alone, it does reduce the risk, but it is not enough. So as we said, when we die, we can't come back. When we're dead, that's it. So we always have to make sure that we risk stratify. Idiopathic VTs, I'll just touch on very quickly. These don't kill you. So they're annoying, they're symptomatic, but they don't really kill us. It's important to make this distinction. Outflow tract tachycardias, you can usually treat with beta blockers, sometimes with calcium channel blocker, which is the fascicular VTs, the left fascicular VT. And catheter ablation has a very high success rate, of more than 90%. Okay, so now fascicular VT, paroxysmal VTs, reentrant, this is all calcium channel dependent, and these can sometimes be sensitive to calcium channel blockers. For the interest of time, I will just go over those quickly. Long QT syndrome. This is actually this is very important because, not because of the inherited ion channel disorder, but which is relatively rare, but because of the medications that will cause long QT and then can sometimes be absolutely disastrous if you add them all together. For example, somebody who's an antidepressant, antipsychosis, gets a cold and gets prescribed azithromycin, and then all of that together prolongs their QT, and then the patient ends up with a torsade and sudden cardiac death. This can happen. So it's important to make it is important to stress this a lot. So long QT is, there's all these different criteria and diagnostic criteria for long QT syndrome, but generally speaking, if you have a QT that is a QTC, a corrected QT, more than 480, then you just have to be suspicious. If it's more than 500, and usually this is the number that we use, for example, when we give patients sotalol, we always have to look at the QTC. If it's more than 500, this is our danger zone. And this is when we say, okay, we need to cut down or we need to stop. The diagnosis is very easy. It's EKG, and there are different types. The genetic part, the long QT1, patients die from exercise. So they go and exercise, and then they syncopize. They don't have to, sometimes they give us warning signs, is that they syncopize. Syncope in a younger patient is not always vasovagal. It is not always the vasovagal syndrome where patients, you put them on a tilt table and then they start syncopizing. It's not always that. We really do not want to miss the small percentage of people, but with horrible outcomes. So exercise. These patients will syncopize with exercise. Some people, long QT2, with startling them, auditory. For example, you're a doctor and you're on call and your beeper goes on, and then you pass out. That is a warning sign. Sometimes, and long QT3 is sleep. Okay, so history is important. All of that stuff is important. I'm going to pass a few slides just because I only have 2 more minutes. So prognosis for long QT, always think about also ICDs. ICDs save lives. ICDs and long QT syndrome. Prior cardiac arrest? Yes, definitely ICD. Recurrent syncope while on beta blockers? Yes. Now, I don't know anybody who wants to take the risk of putting someone on a beta blocker for long QT with syncope without an ICD, because that can be very dangerous. This is an important also entity, CPVT, catecholaminergic polymorphic ventricular tachycardia, VT. So CPVT is also a very interesting entity where this is, you put somebody on exercise or stress or mental stress or whatever, and they start developing PVCs. But those PVCs are very interesting in a way that one is positive and one is negative. And these are called bidirectional PVCs. In here, you can find one is positive, one is negative, positive, negative, and this is a bidirectional VT degenerating into VF. Before that, so what I do with my patients, usually I put them on a stress test, and then I look at, and I don't wait for them to, it's not that I'm not doing a stress test for ischemia. I'm doing a stress test for sudden cardiac death. So you want to push that patient to their limit. You want to push them, even if they reach target. You just want to push and push and push until they say, I cannot do it. And at peak, if you find those PVCs appearing bidirectionally, you have to be suspicious for CPVT. And this is completely opposite to the regular PVCs. So if you have somebody with regular PVCs, and those PVCs are coming from some sort of a focus, most of the time when you stress them, those PVCs disappear. And these are usually benign. They could be relatively benign PVCs. Whereas in CPVT, they appear, and they appear sometimes with a vengeance. You can sometimes have bigemini PVCs that are bidirectional. Treatment, also no competitive sports. Beta blockers. and ICDs. Okay, I also want to talk about Brugada. I only have 43 seconds. With Brugada, these are one of the things that can also be missed just because it doesn't always show in Brugada pattern 1. Type 1 is easy to diagnose because it looks like this, right? All you have to do is just look at it, and it looks like a STEMI. Oftentimes in my fellowship, whenever we had a patient with Brugada, we would cath them first because the ER would call a code STEMI, and we would go in and we're like, well, that's a Brugada, but we're going to have to cath them because code STEMI was called. And it would be negative. But sometimes the Brugada 3, you can't really see it. Brugada 1, 2, and 3, you can't really, 3, it's concealed, so you can't really see the Brugada, and sometimes you have to induce it with medications, and that could be, our diagnosis. Brugada is one of the things that can be worsened by alcohol. Again, if you have sudden cardiac death, ICD is recommended. Let's talk about quickly, time is up, okay. Okay, I want to say, one take-home message, ICDs save lives. They do. Beta blockers are also good. Catheter ablations of VTs, they work. In combination of antiarrhythmics, when needed, we would be able to prevent sudden death in many of our younger people. Do not forget beta blockers. Thank you very much.
Thank you, Dr. Mohammad, for this very thorough presentation.
Thank you, Dr. Mohammad. Our next speaker will be Dr. Aeham Rabadi. Dr. Aeham is an interventional cardiologist practicing in King Hussein Medical Center. Dr. Aeham will talk about stenting or not stenting a patient with STEMI.
Good evening, everybody. Thank you to stand till this late talk today. Today I'm going to talk about deferred versus immediate stenting in ST segment elevation myocardial infarction patient. It's a case report. He's a 28-year-old male patient, smoker and medically free previously. Referred to Queen Ali Heart Institute after 2 hours of receiving thrombolytic therapy for acute anterior myocardial infarction with persistent ST elevation in the anterior leads and persistent chest pain. Echocardiography showed anterior apical severe hypokinesia with normal LV function. Here is the angio, as we can see. In the LAD territory, proximally at the site, in the site of large septal, there is a haziness with apical total occlusion of the vessel. In the LAO caudal projection, we can see the haziness now clearly at the septal area, in an area of trifurcation with 2 large diagonals. So the plan was here to restore the flow in the apical area of the vessel with a low profile balloon and milking the distal bed of the vessel with using of intravenous nitrate to restore the perfusion. Here, the decision of putting a stent was deferred for a period of time to see what will happen with that thrombus at the trifurcation, which may cause total occlusion of 2 large diagonal at the site of the thrombus. So the decision is defer the stent now, get a good flow, TIMID 2 to 3 flow in the target vessel or calbrate vessel, keep the patient on dual anticoagulants with dual antiplatelets on the CCU for a couple of days. We keep the patient for 5 days, and after 5 days, we recath the patient, and we found, sorry, this is the same one. Okay. This is after minimal intervention, minimal invasive mechanical intervention. And after 5 days, we repeat the angiogram and cath, and we found a good flow, TIM3 flow in the vessel with no any residual evidence of the thrombus at the septal branch site. So, what's deferred stenting strategy? The strategy of deferred stenting represented a radical change in the management of patients with ST elevation myocardial infarction during PCI, especially if they have a high thrombus burden. The stent placement is delayed by a finite interval after the index procedure when a stable distal flow has been restored by PTCA or thrombolysis. Here, when we talk about PTCA, mostly we are talking about minimal invasive mechanical intervention by a guide wire, a small low-profile balloon, aspiration catheters, and adjuvant intracoronary medical management like nitrates and glycoprotein 2B3A. So what's the potential advantage and disadvantage of this strategy? The advantage, first of all, we have the gradual clearing of the thrombus burden and resolution of vasospasm that happens within acute coronary syndrome. These 2 points cause selection of larger and shorter stent and prevention of malapposition of the stent. Other thing, that this strategy improves of microvasculature flow and prevent of distal embolization, and that make avoidance of slow flow nor flow phenomena. Also added an advantage, it's prevent pre-procedural myocardial infarction this type of myocardial infarction. Because of the procedure and the stent, we may cause a myocardial infarction intracath. And in some cases, it can lead to total deferment of stent implant deposition. So as this case, after 5 days, we see that's no need for any stent implantation. And what about the disadvantage? The disadvantage are mostly 3 main things. First of all, at the deferral time, there's an increment of re-occlusion of the target vessel. That is somehow controlled by using of dual anticoagulant therapy during the deferment time. Second thing, we increase the risk of bleeding by using dual antiplatelet and dual anticoagulants. For that thing, we can define our patient who is high risk by using the Crociade bleeding score for acute coronary syndrome patient. With high score, low molecular weight heparin enough for very high score for 72 hours. For high score, we can use a bolus of glycoprotein 2B3A intracoronary in the index cath, then continue in low molecular weight heparin. And in low risk patient, we can use both of them intravenously, infusion intravenously during the different time. Prefer to be for glycoprotein 2B3A according to the researches up to 16 to 24 hours of the duration, then continue just on low molecular weight heparin. Third thing, we prompt hospitalization of the patient. As we can see, this acute MI for 7 days, for 10 days, that increase the cost of management of this case. Somehow, if we put in the other hand, the benefits of deferred stenting by decreasing the incidence of heart failure of these patients or no reflow and the salvage myocardium, it's may worthy because in the long run, if this patient retained as a heart failure patient, it will cost a lot. So, I want to talk, but I don't have the time, about how many centers, non-randomized trials talking about this subject. There was a lot, and randomized controlled trial, I will say the biggest 2 till now published is Deferred STEMI and Dynamic-3 Deferred. They are the opposite to each other. The first one said that there is a beneficial effect of deferred stenting strategy with decreased with increased myocardium salvage and improved outcome with decreased major acute cardiac event, decreased percent of heart failure in this patient. But Dynamic-3 failed to show any benefit of deferred stenting. Innovation study is a South Korean study. They point talking about other stenting of the target vessel in the future, and they say that the endpoint within 6 months, no difference, but after 1 year there is a difference with a benefit of deferred stenting because we choose a larger, shorter stent. And the meta-analysis data said, let me talk about them a little because they took this meta-analysis. They discuss all the non-randomized trials and controlled randomized trials. Frexia et al. Said it's a safety strategy. Re-occlusion is 1% during the deferral time, improved LV function, and lower major acute cardiac event. Caio et al. Says no difference in the slow flow nor flow phenomenon, but it's improving the LV ejection fraction with time, and no difference in major acute cardiac event with time. Cassius et al., the conclusion is that they say about the indication for that. They say that the indication of deferred stenting is high thrombus burden and long lesion in the artery, target artery. So, what should be the ideal deferral time? The ideal deferral time, most of the researches and studies talking about now about 5 to 7 days, but put in our mind the risk of bleeding for the patient. So according to the Crusade bleeding score, let's say, with high score 3 days, with low score, so risk of bleeding low, 5 to 7 days is the ideal time. How to select patient for deferred treatment? Start with the indexed cath. If there is no flow or TIMI 0 to 1 flow, we start with minimal invasive mechanical intervention. If we restore the flow, we ask ourselves the question, is this a high thrombus burden vessel with a length more than 24 millimeter of thrombus, or there is a signs of high risk features for slow flow? If the answer is yes, now the deferral strategy is applicable, and we can apply it for 5 to 7 days on low molecular weight heparin and glycoprotein 2B3A, and check again the second cath. If there is a residual stenosis and a large vessel more than 2 millimeter, so standard PCI. If there is no residual stenosis or a small vessel, we can keep this case on medical therapy just. This is future direction. I will jump over them. The conclusion: heavy thrombus burden is not uncommon during PCI for ST elevation myocardial infarction and is an important contributor to the slow flow nor flow phenomenon. Deferred stenting aims to lower thrombus burden and improve TIMI flow during the determined time with the help of anticoagulants. Multiple studies and meta-analysis have shown benefits in terms of reduced slow flow nor flow, improvement in ejection fraction, and decreased major acute cardiac event in some. A routine deferred strategy has not shown to be beneficial and is definitely not advisable, but cases with high thrombus burden, longer lesion, high risk feature for slow flow, and those with suboptimal TIMI flow after thrombus aspiration can be candidates for deferred stenting. The ideal window for deferral is a matter of debate, but longer deferral periods up to 5 to 7 days have proven to be safe and are advocated. Adjuvant parenteral anticoagulation is essential. This is the references for who wants to read more. And thank you very much.
Thank you, Dr. Aeham, for this excellent presentation. We'll take the questions at the end of the session. So we'll move forward, and we'll have Dr. Kamal Hamayel, the bifurcation lesion approach. Dr. Kamal.
Good evening, ladies and gentlemen. Thank you for invitation. Thank you for giving me this opportunity to be here in Amman. My name is Kamal Hamayel. I'm an interventional cardiologist in Jerusalem. This is my presentation. I will turn you back to the bifurcation lesion that we start with in the beginning of this day. So this is my case. I perform it in Jerusalem with Dr. Rami Jabba. He's unfortunately not here, but I will proceed with my case presentation. It's not working. Where's the... Okay, so I'm talking about 65 years old male heavy smoker with a lot of cardiovascular risk factors, including diabetes. He presented to me because of 2 months of effort dyspnea and angina for 2 months. We perform an echocardiography and we find that the patient have a moderate LV dysfunction with the ejection fraction less than 40, have a mild MR, mild TR, with, and the patient taking this chronic medication, including aspirin, beta blockers, ACE inhibitors, statins, with treatment for diabetes. This is the ECG for our patient. The patient have, if you can see here that he have a poor aortic progression in the anterior lead, with no ST segment elevation or depression, a sinus rhythm with a little bit interventricular conduction delay maybe. So we proceed for a cardiac angiography and we defer and we skip the other non-invasive testing because it was like pretty sure that the patient have a cardiac angina and we don't have to go for another non-invasive testing, and that's why we go for the elective cardiac angiography. This is the RCA. First of all, the cranial view for the RCA that shows that you have a critical lesion in the mid-RCA. This is another view for the same lesion. The left system that shows the marginal with the margin, obtuse marginal with the significant lesion, and the left circumflex also that have a significant lesion. The LED here that we have a bifurcation lesion with the second diagonal. If you look to the lesion here, that you find that the LED in the middle of the LED that we have lesion just proximal to the side branch and just distal to the side branch, and the side branch is stenotic with the ostial opening of the side branch, the diagonal, which is a bifurcation lesion according to the Medina classification. It's a 1-1 lesion. So we summarize the patient to have LED mid with a bifurcation, have a triple vessel disease with a LED mid with a bifurcation lesion to the second diagonal. The circumflex is diseased. The marginal is diseased with 70% stenosis, and the RCA with a critical lesion. And that's why in our heart team, we discuss the case, and we find that the patient can benefit from the CABG, but the patient refuses this option totally, and he asked us for another way for revascularization. He was absolutely, he don't want to do the surgery, and that's why we get for the plan for our case. The plan was to perform the PCI for the circumflex and the obtuse marginal together with the RCA, and a staging PCI for the LED and the diagonal, second diagonal of the bifurcation lesion. So we proceed in the admission for the PCI for the RCA. This is the critical lesion, and this is the stenting of the RCA, uncomplicated, uneventful, straightforward opening of the RCA, and everything is all right. And we go for the left circumflex and the marginal, the same here. We go for stenting, 2 stents, and one in the obtuse marginal and the other in the left circumflex with good revascularization with no complications. And we finish the first session. We discharge the patient with aspirin and Brilinta, and we ask him to return back to us for doing the bifurcation. After a month, the patient returned back to us with this bifurcation that we talked about. He's asymptomatic with no chest pain, but we have a critical lesion here that we have to deal with. This is the extra backup guide. Shows that the cranial view shows the bifurcation, not just only a true bifurcation, it's a complex one with lesion, with the side branch, with ostial lesion, which is angulated more than 70 and even more than 90, if you look well to the bifurcation with the side branch. So it's not an easy bifurcation lesion. So we ask ourselves what strategy that we have to choose in this situation. Are we going for the provisional strategy with leaving the diagonal alone, or going for the 2-stent strategy? And I'm sure that the majority of you will choose the 2-stent strategy, but we have another question here: what technique of 2-stent strategy that we have to go for? So this algorithm, I'm sure that a lot of you that know this algorithm, that when you look to the side branch, you have to decide if the side branch is important and it's big enough, giving a supply for the big myocardium. So when the side branch is about 2 millimeters in diameter and supplying a lot of a big geography of the myocardium, you need to preserve it. So we'll skip to the other question, the likelihood of side branch occlusion. And when you see that the side branch have an ostial lesion, you know that this side branch is going to be occluded. So it's high risk to occlude this side branch, and that's why we're going for the third question, the side branch angulation. So this angle, it's more than 70. It's big angle with this ostial lesion. We need to choose a 2-stent strategy, one of them, and we like the DK crush, double kissing crush technique. And that's what we're going for. So this is the guide wire. This is the wiring of the LED. The BMW wire crosses easily to the LED, crosses the lesion and going to the LED. But the challenging here was wiring the diagonal. We used cyan blue wire, cyan black wire, but we failed to, with several attempts, we failed to wire the diagonal, and that's why we skipped to another support by using the angulated microcatheter with Supercross 120. This microcatheter helped us to direct the wire while using the wire inside the diagonal, but unfortunately, in this situation, we see that the wire slipped inside the diagonal here, and it was difficult just to push it inside the diagonal. And here, we have to look for another situation to make a more support for this patient, for this diagonal, for this wire to insert the diagonal, and that's why we use the balloon. We inflate the balloon just distal to the side branch here, and with a microcatheter, we introduce the Fielder XT wire, going inside, trying to advance it in the diagonal, and here the wire is getting inside the diagonal, and even the angle was more than 90. It's just become smaller after we wire it with the Fielder XT. So we have two wires, one in the diagonal, one in the LED, and here we start to lesion preparation and to do like a modification of the lesion in the LED and the diagonal. Several attempts to inflate a diagonal proximally and distally, and here we are going for the LED proximally and distally. We're making a good lesion preparation and lesion modification, and we start with the deca crush here. First of all, that we put the stent in the diagonal proximally to the mid of the diagonal. We put here the waiting balloon. This balloon is waiting for its position. It's not working now, but it will work after that. So we inflate the stent. We implant the stent here. We implant the stent here, the diagonal. We make another like proximal optimization. We pull back the balloon and making a proximal optimization of the same stent in the diagonal. You can notice here that the balloon is still waiting for its position in the LED, waiting for the work. We don't give him an order to work yet. But here, when we implant the stent, we implanted just protruded a little bit inside the LED, and here we did a crush. We inflate the balloon in the LED for 18 atmospheres, and this doing a crush. After that, we did a first kissing with the balloon inside the LED, inside the stent inside the diagonal, inside the stent, the diagonal, and the balloon in the LED. And we remove the wire from the LED now. We have just a wire from the diagonal, and we have just a wire in the LED. We put the long stent, and the long stent we implant it in the LED between the proximal to the side branch and distal to the side branch. And here we did a rewiring for the diagonal with a second kissing. We looked at the spider view to see what happened with the proximal part of the LED, and we find that the LED still have a proximal lesion, so we put a small stent for 15 millimeters proximal to the LED. So this is the final result: two wires inside the diagonal of the LED with a good revascularization. This is the proximally that you can see the proximal part of the LED is good. It's good vascularized, and it's a good diameter. Here, without the wires, we have this result. And when you look to the beginning of the case, you show that you can see the difference between the beginning of this case and the end of this case. So, thank you for your listening. I'm ready for questions.
Since you are here, please stay here, and we'll have questions on his case, please. Any questions? Go ahead.
It was very good, but I am wondering why you put your wire inside the stent while you are crushing it. You didn't pull the stent while you are crushing the stent of the diagonal.
First of all, it was difficult to wire the diagonal.
And even the balloon was there when you are crushing the stent.
Yeah, we have to crush it while the wire inside, right? To make it first of all, to make a marker for us for the second wiring, and I don't have to crush the. I don't understand the question. but-
Sir, your strategy was classical decay crush or mini decay crush? The classical. So in the classical, you protrude the stent in the main branch
Right.
in good length.
Yeah.
When you have a wire and you crush it
Yeah.
by a sizable balloon, sometime, and even the balloon was there, sometimes it is difficult to retain these pieces. When you fracture the wire
No,
because
no,
you
I-
crush the stent.
I think he
And even the balloon.
rewired. I think he rewired and went with another balloon.
No, he didn't. While he is
First
crushing the stent,
First of all, we implant the stent, okay? First of all, that we implant the stent in the diagonal, and we crush the stent there.
And the
we
wire-
pull out.
and the wire is
was
still
out.
there.
The wire was out.
out.
Yeah.
ممكن احكي شوي لو سمحت. الواير اعتقد الواير لازم يضل جوا لان حتى لو يوم مسوي كراش
The
ما
classical crush.
ما في مشكله بس لانك انت يوم تدخل في الواير الثاني مهم تعرف وين الواير الاولاني عشان تعرف اي منطقه تدخل. فعشان هيك اعتقد مهم جدا تترك الواير جوا وتسوي كراش first stent with two balloons according to proximal segment to crush the stent. Then you can go with another wire more mid segment or
But this is not the step of the classical crush. When you
Dr.
crush the
Yunus-
stent, you have to pull your equipment. You crush and then you rewire.
Dr. Yunus, you are talking about a different technique. In decay crush, you should remove your wire before crushing your stent.
No,
It's mandatory.
If your procedure was
You
mini
sh-
crush,
you should.
you can put your wire as far as there is only one truss outside
I will
the
answer
side
the
branch.
question. I will answer the question. When I did the crush, the wire was inside.
Yeah.
And after the crush, we did kissing balloons. After the crush, after we crush it, we did kissing
First
balloon
kiss.
with the balloon. We use the balloon of the stent itself. We don't put it-
No, but what about the wire when you crush the stent on the wire and you are compressing the wire and you have to recross from other side?
We cruise it after we remove the first wire. But we did kissing, first kissing while the wire inside. And after that, we take it out and we did rewire.
It was easy to take the wire outside.
It was easy to cross that because the angle, I think that the first kissing gave us an opportunity to get inside with this wire. It's the first pull.
If I, instead of you, I will choose the DK, or not the DK, the double crush kilowatt will be more easier for me for this very angulated diagonal.
I think it's a good possibility and it's a good technique. I think you are right.
More easier for you.
In our policy, in our hospital, we do a lot of ticket crush, and that's why we go into this forward, and when we look to the angle of the diagonal, and after that we put the wire, and we see that the angle is getting smaller, so we choose this way to do the ticket crush before another step, and we have a good experience.
So
Anyhow,
you
your
are
final result were
doing,
very
Just to
good.
clarify the point, Munde,
so you are
for
doing
the,
triple kissing.
just to clarify the
Not double
point
kissing.
for the DK crush منذر
Triple.
لأنه في
هذا-
confusion كثير على موضوع DK crush. The wire you can crush while the wire is there, but actually your stent is 10 millimeter inside the main branch. It should be 2 to 3 millimeter maximum for the DK crush. It is 10 millimeter inside the main branch. This is too much. This is too long. I have never seen wherever I see it. I did not see a DK crush with 10 millimeter from the side branch.
You're talking about the diagonal, right?
Yes, it should not
But
be 10
right.
millimeter inside the main branch.
Right.
The classical crush.
To make it
But 10
clear,
millimeter is too long. 2 to 3 millimeter, even the classical crush. We don't crush 10 or
Doctor-
20 millimeter inside.
Dr. Rai,
No,
to make
we-
it clear, please, to make it clear, the classical teaching for DK crush is to remove your wire before crushing the stent. Okay? Sometimes with your experience you can leave it, but the classical teaching is to remove the wire and rewire, then you will do the first kiss.
The point of the crush, we don't want to increase the metal. The metal, when you go to 10 millimeter in the, from side branch to the main branch, this is too much metal also. Also, we need to decrease the metal. So 2 to 3, it is not more than 2 to 3 millimeter actually with the crush. And now we are talking about nano crush. Nano crush even less than that. But anyhow, it's good safe, but you need imaging after that. You need to do IVUS or something to see what's going on.
Thank you.
العفو. سؤال للدكتور محمد ممكن؟
Yes.
الأخ دكتور محمد, according to guideline دكتور محمد, according to guideline treatment of VT presumed to be ischemic in origin, treatment cabbage class 1A, PCI class 1C. This is one. Regarding another question, what about indication of beta blocker in prolonged QT interval? And you mentioned only prolonged QT interval as a cause of VT and VF. What about short QT interval? Also, it can precipitate VT and VF.
Yes, thank you very much. So if VT is caused by ischemia, obviously you treat the underlying ischemia and you don't have to put an ICD. So this is something I didn't mention because I presumed that I wanted to talk more about the sudden cardiac death in younger patients. But absolutely, if somebody comes with persistent VT and you cath them and you find a tight lesion, then you treat the tight lesion and you do not put an ICD if you think that the tight lesion that you treated is really the cause of VT. So and here comes a very important kind of distinction, is that if you cath someone and you find a tiny lesion, tiny artery, and you're not sure that this is actually causing a significant ventricular tachycardia that might cause sudden cardiac death, then you have to be suspicious. I mean, there's one thing, stenting an LAD, a large LAD that's causing VT and that's going to kill someone. And another thing is finding a tiny artery that may or may not cause the VT, and that might be an incidental finding. And in these people, sometimes we do an EP study to make the distinction and see is that after you treat the ischemia, then if that VT is still inducible, then we want to put an ICD in and prevent sudden death. But if the VT is not inducible, and we're talking after VT, after 48 hours, and is very different from the 48 hours peri-infarct, then you do not put an ICD if it's not inducible. As for QT, yes, short QT is a rare syndrome, and this is very difficult to treat because short QT, you do put in an ICD, but sometimes the ICD, because of the QT is really short, the ICD does not really differentiate between the T wave and the QRS. So that's also one of the sudden cardiac death causes. It's exceedingly rare. For beta blockers for long QT, that is a very important mainstay treatment. The beta blockers that we use, there are two beta blockers that we like to use. One of them is Inderal, and the other one is propranolol is thank you, is Inderal, and the other one is Nebivolol, these are the two beta blockers that we usually like to use in long QT, but they are mainstay treatment. But if you have syncope, and the syncope is with long QT, despite the beta blockers, you want to put an ICD because you don't want somebody to have a presentation of sudden cardiac death with brain anoxia or brain anoxia and not be able to help them. I hope that.
Last small question.
Yes.
In the case of resistant VT to all modality of treatment, what is your choice?
Ablation. So VT ablation is.
If ablation is not beneficial.
So one of the things is that you can have. So it depends. The VT, if the ablation is not treating the VT, then you have to think about an epicardial focus. So epicardial VT is also, actually in some centers, they do an epicardial access on every single patient with a VT. We don't do that. I personally don't do that. But if we're thinking that you ablate someone endocardially and that VT is still there, then you want to think about an epicardial focus. There are criteria for epicardial VT, although they don't always apply, like the distance between the onset of the QRS to the peak of the QRS. the MDI. There are some criteria, also negative in lead 1, telling you that this is an epicardial focus, but it's not always the case. So
one statement
yes.
regarding guideline in resistant
Yes.
VT to all modality, we are left just with cardiac transplant.
So in cardiac ischemic VTs, we have to make the distinction between the two, whether it's ischemic VT and non-ischemic VT. And we also want to make sure that a focal VT versus a VT that is caused from substrate VT. So the VTs, it's a whole world of electrophysiological abnormalities. So if you cannot treat a focal VT, we don't really want to jump to transplant, but in ischemic VTs who are, you ablate once and twice and you don't have anything to ablate anymore, and if the patient is young and they've had CABG, they have been revascularized, and they're still having VTs, you can consider transplant. That is correct if the patient is young and if the transplant criteria applies on them. But this is it's more geared towards, it will be a separate lecture of post or ischemic VTs. And it's a huge topic of ischemic VTs where we have revascularization, another revascularization. We look for any focus, but they're still having VTs. We ablate, and the ablation is still not beneficial. Absolutely, we can consider transplant if the criteria is met. So, I mean, if you have an 85-year-old with ischemic VT, you're not really going to transplant them. But if a 55-year-old post-CABG and having VT, then obviously we can consider that. That is, or an LVAD. That's definitely one of the considerations.
Thank you very much.
Yeah, absolutely.
Thank you, Dr. Mohammed. We have a question
yes.
over there.
Thank you very much, Dr. Aeham. You put a highlight on a very important subject. I like and love it, which is the arrhythmogenic right ventricular cardiomyopathy, or RV dysplasia. Actually, in 2006, we have a registry in Iraq for RV dysplasia. We have a team and we have a paper published at بال 2010 أعتقد بالأمريكان ميديكال جورنال of cardiology. البايونير of arrhythmia of electrophysiology in Iraq هو بروفيسور عمار الحمدي. If we concentrate on the ECG, the epsilon wave, in most of the cases of arrhythmogenic cardiomyopathy in Iraq, it was more than 30%. So if you are electrophysiologist like you and Dr. Munir and other, you have a specific look. So he is always mentioned to us, احنا بالعراق يسمونها بهتة يعني مثل السينكوبي dizziness, runs off non-sustained VT. وحتى ألطف الجو شوية يقول إحنا هاي شخصناها العراق شخصها من 1920 عندنا شاعر من الناصرية يقول له يا طبيب صواب دلالي كلف. طبعا قدمها بواحد من الميتنج وبالإنجليزي مترجمها أستاذ عمار الحمدي. يقول له يا طبيب صواب دلالي كلف أغنية الحضيرة أبو عزيز طلعوها اليوم يا طبيب صواب دلالي كلف. الدكتور منير هذه لا تلجمه بحطة السماعة
بعد دقات القلب ما تنعرف
تختلف ما بين ساعة وساعة يعني alteration in the cardiac beats. It was something so if we concentrate on epsilon wave we find it is more in those patients. A very short question to Dr. Kamal. You did a very nice job, Dr. Kamal, but I will ask you about what is the size of diagonal?
What is the size of the diagonal?
Do you think it is small?
No, it's not small. I told you that it's more than 2 millimeters in diameter, even more. I think it's
more than 2 millimeter. Yeah. Yes, it is.
And it supplies a lot of geography in the myocardium, and that's why we have to proceed.
Any moment at that time you think about DCB, drug-coated balloons?
No.
Okay, because the latest news from the Asian PCR, they say the future for more ballooning and less stenting. And thank you very much.
Okay. Thank you.
I have a question.
I have
Dr.
a
Mohammed
comment actually on ARVD. ARVD. You treat it with medication. You ablate epicardial. That's the one you ablate mostly epicardially. and then the disease, the arrhythmia recurs later. And this is because it progresses, and you have more circuits and more problems, so you might have to ablate it again. I have a question for Dr. Mohammed. Do you do a cervical, do you do sympathectomy for long QT syndrome?
Yes, I think
And
that's
if
an
you
amazing
do it,
idea.
Is it unilateral or bilateral?
Yes, cervical sympathectomies is a great idea, but we see it more in a pediatric population, so it's younger patients, and I personally don't treat younger pediatric populations, but yes, I think cervical sympathectomies they are used, and especially in younger patients where it might be difficult to implant.
Okay.
Okay, any other questions?
Dr. Mohammed,
Rashid
سؤال.
has a
Me, I have a
question.
question.
Dr. Mohammed,
I have a question.
about,
Excuse me.
sorry?
I have a question to Dr. Aeham.
Rashid.
Is there an evidence in guidelines regarding deferred stenting in STEMI? I mean, it should be clear for cardiologists. It's not to give them an excuse to not complete a job, especially during STEMI, especially in no-flow situation. You have to digging for causes of no flow before deferring the procedure.
Thank you for the question.
Thank you.
First of all, there is 3 slides, as you remembered. I skipped them because of the shortened time. Most of them are trials between non-randomized, randomized trial, and meta-analysis of a lot. Till now, in the American Society of European Society of Cardiology and AHA, there is no guidelines for deferred stenting to clarify that. And we hope that in the next 2 randomized huge controlled studies, we are waiting for them in 2025 and 2024. They will answer and there will be guidelines for that. But till that time, all of the studies shows the deferred stenting, you have to select. I said in the conclusions or the peers points at the end. It's not the choice at the beginning. It's your choice as an interventionalist. It's class 3 for your experience. If you feel that putting a stent primarily will be harmful for the patient because of a lot of things, so don't do it and give a chance for yourself, okay, to take a very clear decision later on. So the answer is there is no clear guidelines to use a deferral strategy. Thank you very much for your question.
Dr.
Okay,
Isa.
I think, okay, Khalil.
Thank you, sir. Question for Dr. Mohammed. Thank you for your nice presentation for the sudden cardiac death. I want to ask you actually 2 questions. The first one, what's the clinical correlation between ECG findings of HOCM with echo? Sometimes we find a patient with typical HOCM on ECG. Narrow Q, deep, giant T wave, LVH, and echo is normal, typical normal. Many patients.
Yeah.
We suppose that this patient have positive family history. What we can approach for him? The second question was about the apical HOCM. Without any asymptomatic apical HOCM and without any risk factor for him, just apical HOCM. The guidelines for,
Go ahead.
guidelines for the apical HOCM class 2A for ICD, but when?
So these are really important questions, especially the first question. I always ask my students that, where when I show them the ECG, and I give them little blurbies. So remember that the ECG criteria are only for patients who are above 40 years old. So the LVH criteria does not apply on anyone who is 15 or 20 or any
Or
younger
thin
people.
Yes.
Exactly. So if you are 20 and you have big LVH, that doesn't really mean anything. It doesn't necessarily mean anything. But if you have deep T-wave inversions, then that is a more important, a more concerning sign to me than having LVH. So I think that may be it, because all the studies and all the LVH criteria that were published are for patients above 40 years old, and they were never done on somebody who's in their 20s. But we extrapolate the data anyways. So that's for the one. So if you suspect it, a quick echo is not really going to hurt. But the clinical picture is much more important. If you have somebody with syncope, if you have family history, just be suspicious. I feel that sometimes we may overlook syncope because there's so much vasovagal. And you know, what's common is common. And most common is not sudden cardiac death. What's most common is vasovagal, right? They see some blood, it's hot, they just syncopize. And that's much more common. But we don't want to miss a sudden cardiac death because death is irreversible. So that's for your first question. And the second question is for Yamaguchi. Yamaguchi is a little difficult because initially Yamaguchi was considered a benign disease, but there were some published case studies where there was sudden cardiac death in Yamaguchi patients, and that made it a little more questionable. There's a I can't remember I think it's around 7% risk of having some VTs, but it's supposedly more benign. But personally, if I see Yamaguchi, I do implant ICDs. I tend to be more aggressive. Maybe that's just, I mean, the way I trained is just I tend to be more aggressive when it comes to things like sudden cardiac death. I'm much more lenient with smaller things, but when it comes to things like death, you really don't want to take the risk.
Thank you, sir.
Thank you.
Thank you. I think by this we conclude our session, and this is the end of the first day of the conference. Thank you very much, and have a good night.